Hey guys, welcome back to Man Medicine, where we talk about maximizing your health and hopefully avoiding the collapsing U.S. healthcare system. So today we're going to talk about a subject that many men are uncomfortable with, they're embarrassed about, and that subject is erectile dysfunction. And I'll cut to the chase. The whole point of this little talk of mine is going to be to encourage you guys not to blow this off, to get a professional medical evaluation either from your primary care physician or your urologist if you're suffering from any degree of erectile dysfunction. And the reason I say that is that this problem is often the first sign of a larger problem going on. It's a harbinger potentially of something serious that could be waiting for you down the road if you don't address it. So what I don't want to happen is have you guys pop into your GP's office, say, hey, by the way, could I get a Viagra prescription? They're busy, they'll just write it for you and send you on your way, and not look further into this. Or even worse, go to some shady internet website and get yourself some generic Viagra or Cialis and never even see a doctor, which I know that some guys do that. I'm hoping by the end of this talk you'll see that why that's a major mistake, and that you really need to take this problem seriously. The first thing to know about ED is that it is extremely common, okay, and it's becoming more common. The Massachusetts Aging Male Study was a study that came out. It's really old now. I think it was in the late 80s, like 88 to 89 or whatever. In that study, they looked at a number of different things, but one of the things that they looked at was erectile dysfunction, and what they found was that it was extremely prevalent. And this is back in the late 80s, maybe early 90s. I can't remember the exact date of the study, but what they found was roughly 40% of men age 40. So 40% of 40-year-olds back in the late 80s, early 90s had some degree of erectile dysfunction, and 1 in 20 had complete ED, meaning that under no circumstances could they obtain an erection at all. Which is a little bit terrifying. And then that number went up basically like a percentage point for every year after that. So obviously, like by age 70, you were likely to have a 70% chance of suffering from some degree of erectile dysfunction. Now that doesn't mean total ED, but it does mean that more often than not you're struggling to maintain an erection that's adequate for intercourse. And then obviously, as you get older too, the number of guys that had total ED, meaning completely unable to get an erection at any time under any circumstances, that went up too by age 70. I think it was like 15%. So this is a real problem. So, I'm willing to bet that those numbers are lower than what really is the case, because, for obvious reasons, I think this is something that's probably underreported by men. It's not something they like to talk about. Again, it's a source of embarrassment, but I want to encourage you guys to talk to your doctor about it and do your best. Try to shed that stigma that you've placed upon yourself, because this is a medical problem just like any other medical problem that you may encounter as you get older. And the sooner you address it, the better your chances of not only correcting it, but at least maybe not making it any worse than it already is. So I don't want to get too deep into the mechanics of how erections happen, but I think it's important to look at this as this is a vascular event, meaning that it requires adequate blood flow through patent arteries that are able to both constrict and to relax at the appropriate times. There's obviously neurological components and endocrine components. There's obviously huge psychological components which can be playing a role in this too. And so you have to address all those as well. But most ED in older men, it has a vascular cause. A lot of guys think that testosterone is the cause. So I got low T. That's not the cause, okay? So I want to show you this little pie chart here. It talks about the major causes of ED. All right, and you can see that the bulk of these, we're looking at vascular disease and we're looking at type 2 diabetes, okay? Combined, that's 70% of cases of ED. Now, really, this 40% chunk that's due to diabetes and this 30% chunk that's due to vascular causes. There's massive overlap here, and really this is the same process when it comes to looking at the blood vessels. So I just kind of lump these two together. People with diabetes, obviously they have neurological problems, they have neuropathy, but they have vascular disease. It's not a question of if they have vascular disease, it's the question is how much. And obviously not everybody with vascular disease has type 2 diabetes, but again, if these were two circles, they would overlap significantly. But the other thing to point out here is, this little pink chunk here, endocrine disorders, 6%, and that's referring to testosterone, specifically hypogonadism. So it's not believe it or not, it's not a huge player in all of this. In fact, the American Urological Association put out some ED guidelines like back in 2018, and this is a quote right here, right out of that guidelines that I've highlighted. It says, testosterone therapy is not an effective monotherapy for ED. 100% true. If the man's goal is amelioration of ED symptoms, then he should be counseled regarding the need for ED therapies in addition to testosterone. Okay, that's really, really important. This is actually one of the myths that I have to bust a lot in guys that are interested in starting testosterone. If they come into this and their primary problem is erectile dysfunction, and that's why they think they need to be on testosterone, it's usually not the problem. It may be a component of the problem, and I'm not saying that testosterone can't help certain men, but this is certainly not an overnight fix, and you have to combine this with other therapies. In fact, if you're a man with low testosterone and you're using things like Viagra and Cialis, you might get a suboptimal response from those meds until you correct the testosterone issue. And the two of those actually work really well together. But as monotherapy, testosterone generally is not going to fix your problem. So I want to dispel that myth right away. And I'm really glad that the Urology Society talked about this and explicitly stated that, because sometimes I feel like I'm a broken record talking about that with guys. So again, this is a vascular phenomenon. If you're experiencing ED, you have a blood flow problem. And a lot of times that is narrowing of the vasculature either in the penis or in the blood vessels that lead to it. And this is a really scary diagram that I like to show a lot to drive this home. And it shows the diameter of the penile artery, which is one of the main arteries responsible for sending blood to the penis. And it shows it in comparison to a coronary artery, your internal carotid artery, and then your femoral artery down in your groin. So the penile artery is tiny. It's tiny. It's 1 to 2 millimeters. Okay, tiny little artery. These other arteries are much bigger. So you can imagine that, it doesn't take a lot of atherosclerosis, a lot of cholesterol plaque to completely plug up this penile artery. You may have significant plaque in your coronary arteries and your carotids, for example, but it takes a lot to hit like a 50% threshold where maybe you start to have symptoms with exertion, or maybe your risk of like stroke, TIA, MI starts going up. But compared to the penile artery, you don't need much vascular disease to completely occlude that, or to certainly like occlude it beyond the 50% threshold, which is typically where you can expect to get some symptoms. So this is why I say that erectile dysfunction, this is a harbinger of things that are going on in other parts of your body. There's nothing special about your penile artery. If you have plaque in your penile artery, you probably have plaque in other places too, like your heart, in your brain, carotid arteries, in your peripheral vasculature too. It's all the same process. So this is a blood vessel disease in many cases. And as you get older, naturally your blood vessels become more stiff, they become more calcified, so their ability to contract and relax, which is key to getting an erection, that starts to become compromised. Even if you do everything perfectly, this is a natural process that comes with aging. But lifestyle stuff, not taking care of yourself, ignoring other medical issues, certainly smoking, things like that. All of these things accelerate cardiovascular disease, but they accelerate that through the acceleration of atherosclerosis, which again is one of the main causes for erectile dysfunction. So again, this is why I say don't blow off ED, because this is a sign of a bigger problem. Now, before I go into exactly, what I think your doctor should do, and or I'll give you some examples of what I do when I evaluate a man for ED. There are certain things that are kind of like low-hanging fruit that probably should be looked at. And a big one is medications. There's a long list of medications that can cause ED. So blood pressure medicines in particular, thiazide diuretics, things like hydrochlorothiazide and chlorthalidone, which are great blood pressure medicines. I think chlorthalidone's great. It's associated with ED. Beta blockers. So a lot of older men, especially older men that already have established heart disease, heart failure, coronary artery disease, etc., beta blockers can cause erectile dysfunction. So if you're a younger guy, I stay away from thiazide diuretics, stay away from beta blockers if you can. You may have some reason why you have to be on those meds, but in general, that definitely can do it. A little bit less commonly used, things like spironolactone and clonidine, both can cause erectile dysfunction. ACE inhibitors and angiotensin receptor blockers are great. They do not typically cause ED or any erectile issues. In fact, they can improve the health of your vascular system over time. So that's kind of the go-to, I think, if you're a younger man and you need some medication for blood pressure. I've done other talks on ACE inhibitors and ARBs. I do think many of them have potentially life-prolonging properties to them. They have a very good side effect profile. Some you don't have underlying serious kidney disease. They're good drugs. Antidepressants are another huge one. SSRIs, all of them are associated with erectile dysfunction to one extent or another. Some of the big offenders are like Paxil. Obviously Zoloft can do it. You also can see it sometimes with Celexa, Lexapro, a little bit less with those. But then there's a whole ton of other like antidepressants that are not SSRIs, SNRIs. Those are all potentially associated with ED. One that you may not know of is proton pump inhibitors. And I actually learned this kind of recently. There is an association between taking a proton pump inhibitor, which is a medicine for reflux. So, your little purple pill, your Nexium, your Prilosec, Asphyx, whatever. Those are associated with some degree of endothelial dysfunction. And it's reversible when you stop the drug, but that potentially could be contributing to ED. So, you can talk to your doctor if, you may need to be on those if you have severe GERD. I mean, that can be pretty miserable. And obviously I don't want you to get Barrett's esophagus and, bleeding ulcers, all that kind of stuff. But that could be potentially playing a role. And then, there's certain lipid medications, some of the fibrate medications, which get used sometimes for people that have very high triglycerides. Statins get a bad rap, but they shouldn't. Statins don't cause ED, in my opinion. In fact, they're one of the mainstays of treatment for the underlying processes that lead to ED. So, if you've got established atherosclerotic plaque, that's an indication, in my opinion, to consider statin therapy. And that's something you have to talk to your doctor about. It should be done on a case-by-case basis. But, if you're on a statin and you're experiencing ED, it's probably not the statin, in my opinion. Obviously, talk to your doctor about that. Okay, so what needs to get done? Well, when you go in to see your doc, first of all, just be open and honest, answer all the questions. This is not something you need to be embarrassed about. You need to give your doctor, just like any problem, give them as much information as you think is relevant. And, even if you think it may not be relevant, you never know. You should probably, just disclose everything. Give your doctor as many tools, as much information as possible when you go in. But your doctor needs to do, it doesn't have to be a thorough physical exam on you, but, they need to look at your stuff, okay? There's a number of things that, could be related to this. You could have a varicocele, which is like a big dilated vein in the scrotum. You could be developing this like fibrous plaque on the side of your penis, and that's called Peyronie's disease, which is potentially very serious. You may have a testicular mass. You just never know. So they need to do a physical exam on you to begin with. But this is a great time, if you haven't done it already, to go in and get a complete physical and specifically get blood work addressing cardiovascular risk factors. Because again, this is a vascular process in the majority of men. So what does that entail? I like to get a hemoglobin A1C. We've got to screen for diabetes, right? Your doctor will get a CBC, complete blood count, even though that's probably not particularly helpful. It's good to screen for liver disease. It's good to screen for kidney disease. These things are not, they're not that common in the general population, but they are out there. Getting a PSA, prostate specific antigen, that's for older men. It should be done on a case-by-case basis, and ideally you weigh the pros and cons, because PSA is not a very specific test, and it can lead to a lot of unnecessary testing if it's high. Some doctors like to get it routinely. For me, I like to have that conversation first. I don't routinely get PSAs. I do screen my guys for thyroid disease, but yeah, quite honestly, that's not a major contributor. Like we talked about, the endocrine causes of erectile dysfunction are really just not that common. Getting a testosterone level, I think, is important. But we do want to screen for hypogonadism. I like to get a UA, looking for some white blood cells, red blood cells, maybe looking, potentially if there's a chronic prostatitis that could be, contributing to this. I ask questions about sleep apnea, because that's a big one. And a lot of these guys that have erectile dysfunction are already overweight, they're obese. Many of them also have sleep apnea, and treating sleep apnea is another thing that can really help erectile dysfunction. Because again, sleep apnea, I've talked about this in other talks with you guys. It puts a major stress on your cardiovascular system. It accelerates cardiovascular disease. It raises blood pressure, which obviously causes damage to the lining of the blood vessels. So ED can be an end result of that. So if you got sleep apnea, for God's sake, get it checked out. Use your CPAP. It can really, really make a difference. Blood pressure, can't talk enough about that. It's a major cardiovascular risk factor. If you want to keep your pipes clean, you got to have low blood pressure. And maybe you can get there with diet, lifestyle, and weight loss. A lot of guys can. You may need medication for it. If that's the case, listen, it's not the end of the world, okay? Maybe an ACE inhibitor, maybe an angiotensin receptor blocker. Alcohol's a big one, guys. Especially as you get older, you can't get away with knocking back cocktails and then go home and expect to perform, especially, like you did in college, potentially. So alcohol's a big one. Smoking, it kind of goes without saying. I mean, there's very few things worse for your blood vessels than smoking cigarettes. So please don't do that. for all sorts of reasons, don't do that. All right. And quite frankly, if you're obese and you really don't have any other issues, obesity alone is associated with increased incidence of erectile dysfunction. So again, for all the other reasons too, besides ED, getting your weight down, getting your body fat percentage down. Again, I don't really care what you weigh. I care about your body composition. Getting that body fat percentage down as low as possible can totally help. And then, let's say you've done all this stuff, this blood work is coming back looking good, and you're still having issues. Maybe you've tried, Viagra, Cialis, some of these PDE5 inhibitors, and they're not working for you. That's the time to ask your doc to get your referral to a specialist. So, specifically a urologist. Urologists go through very long, very arduous residencies where they learn all about this sort of stuff. And if your primary doc has done all of this basic screening stuff in advance, it's going to be really helpful for your urologist, because they don't have to reinvent the wheel when they go in there. And they may want to look and do a bit more, not invasive, but more in-depth testing. And one of those things can be a Doppler ultrasound, where they can look at the blood flow going in and out of the penis, and they can measure the peak velocity. So they'll measure it at rest, and then they'll give you an injection of this stuff called Trimix, which is like a mix of prostaglandin E1 and papaverin and what's the other one, like phentolamine, I think. So they measure your velocity through the penile artery at rest. They give you an injection of this stuff, which forces blood flow in the area, and they measure it again. And you should have this nice, like, big peak velocity. I think if it's over 35, I believe it's centimeters per second. Quote me on that. That's very reassuring. If it's less than that, you might have some blood flow issues. So they may want to go and look into that. And if you have a clogged penile artery or other vessels that lead to the penis, and you've got 70, 80, 90% blockage in there, man, your options are limited. there may be some endovascular procedures they can do to restore blood flow. That's not really my wheelhouse. What I have seen done, and what a lot of men end up doing, is having to go under surgery for the insertion of a penile prosthesis, which you can Google that. I remember scrubbing into one of those surgeries as a third year medical student, and I was severely traumatized. Not really, but it's it's a very invasive surgery. Things are never the same after that. And you can have complications when you have, a piece of plastic embedded in your penis and scrotum, for years and years and years. You can have erosion of the prosthesis. You can have infections. You can have, scar tissue. You can have all sorts of issues like that. So, but the point is, though, if you don't take care of yourself and you do get to the point where now you've got this critical blood flow restriction, that may be your only option. And if that's the case, then that's the case. But, it's one of those things where I can't help but think that, if you intervened on this 20 or 30 years before, maybe you wouldn't be in that situation. So, can't say for sure. I'm not going to, cast blame on people for their problems, but there's a lot to be said for prevention. But it's hard to prevent something if you're not really aware of what's going on. That's the whole point of this talk. So anyway, that's all I got for you guys. I don't want to go on and on about this, but please, if you're an older guy, really if you're a guy of any age, at this point, and you're experiencing erectile dysfunction and it's happening a little bit more often than you would like, please get in to see your doctor about it. Talk about it openly. Ask for some of these tests. It's fine if they want to send you out with a Viagra prescription, but in my opinion, you shouldn't get a Viagra prescription and then no further workup. Because again, a lot of times this is a sign that something more serious is going on. So, all right, guys, that's all I have for you today. Please give me some comments down below if you have an experience, seeing your doctor and getting this worked up. If you have any other comments, any ways that you'd like me to improve the channel, any ways or any topics that you'd like me to cover. That's where I get most of these topics from questions that guys ask me, either through email or my patients that I have personally. So if you want me to address a certain topic, just let me know. All right, I wish you guys the best, and I will catch you next time. Medicine video and audio has been created and shared online for informational purposes only. This podcast does not constitute the practice of medicine or professional healthcare services of any kind, including the giving of medical advice. I am not your doctor. No doctor-patient relationship has been established. This content is not meant to be a substitute for professional medical advice and should not be relied upon solely for that purpose either. The only purpose of this content is to present peer-reviewed, research-backed health information for your consideration. As always, rely on the advice and guidance of your personal physician before undertaking any activity presented here, and if in doubt or not comfortable with said activity, practice discretion. Your health is your responsibility and not ours. Finally, I take conflicts of interest seriously. I accept no compensation whatsoever from any private corporations, including pharmaceutical or supplement companies. You can trust that if I recommend a medication, product, or service, it's because I genuinely believe in it and not because I'm being paid to endorse it.